is Larry Bauer, Chief Executive Officer Emeritus of the Family Medicine Education Consortium, and I'm very excited today to be introducing two people who came together at the 2019 FMEC Innovators Network meeting in Lancaster, Pennsylvania, and have struck up a relationship that's changing healthcare for folks at the Jamaica Hospital in Queens, New York. Let me introduce to you Dr. Alan Roth, who is chair of the Department of Family Medicine at Jamaica Hospital, and Dr. Scott Conard, who is president of Converging Health from Dallas, Texas. And I'm going to turn things over to them and let them tell you their story.
So, Larry, thanks for the introduction. It's true, we met at the Innovators Network. I was an audience participant facilitator in that meeting, and it was great to meet Scott at that meeting. It's something that made a huge change in our lives here at Jamaica and the practice. I watched in awe as he went through data and, kind of really showed me how important the data is in running a practice. And you can't run a practice without knowing your patients, without knowing how sick they are, what's wrong with them, and how to take better care of them. And working with Scott and his team for the last 2 years or so has enabled us to, certainly work much smarter and not working harder. And I stole that from Scott, so I'll hand it over to you.
Well, thanks. Real quickly, I'm going to go ahead and run through some slides, Alan. And, it is, to me, remarkable, like phenomenal how much working with you, Alan, and being able to work with Jamaica is the difference has happened in 3 years. And today what we're going to present is, first of all, the theory behind why we're doing what we're doing, and then secondly, how we're doing it, and then thirdly, what the results are, because we've already got preliminary results. And we really met the fall at 19. So this whole thing began January 1st of 2021. So we've been at it now for 21 and 22. So real excited about it. Alan, can you see the slides okay?
I see the slides, and maybe I should take like 1 minute and kind of just set the scene of who we are. So Jamaica Hospital is part of the Medicis Health Network. We're in Queens County, New York. Queens County, out of the 3,000 counties in the United States, is the most culturally diverse. We have between 300,000 and 400,000 undocumented individuals. And our payment system is about 80% public funded, mostly Medicaid, about 60%, and 20% Medicare. So we take care of a very underserved population, and a very high proportion of our patients are globally capitated, taking full risk and managed Medicaid patients. So kind of sets the scene for, how we were able to, work with Converging Health and Scott and make these changes.
Fantastic. All right. So the first step is data. And what we do is we take the claims data, we take the EMR data out of Epic, and we take the knowledge that the clinic has of their patients, and we put it all together. And what you see here is that clinical risk score that has 3 major components. First of all is the absolute risk. What conditions does the person have? How many medicines are they on? How many doctors are they seeing? How complex is their care? What are the social determinants, which is, of course, with Jamaica, quite impressive in terms of what the patients have to overcome. And so that's the first thing, absolute risk. Second is how well are they being cared for? We have a clinical care score, it includes gaps in care and pathways in care. And then the third aspect is how are they using the system? What is their mindset? How are they engaging? And you put all that together and every person gets a risk score. And then we look at that as a surrogate marker for how they've been engaged in the system. The expense of them being engaged in the system is how much have they spent in the last 12 months. And when you do that, you get a 2x2 that you can see every dot here is a patient. And it puts them into 4 quadrants of risk. The first is the health, the left lower quadrant. And those are the healthy people. We want to keep them healthy. They need immunizations, annual exams, preventive screenings. And we need to make sure they're engaged with their primary care doctor about once a year, unless there's an acute problem or something that changes in their health status, which it does. And you end up with 1 to 2% of the members spending, 2 to 5%. This is people who become pregnant, which is a lot of people in Queens at Jamaica. Appendectomies, gallbladders, accidents, ER visits, et cetera. And so that people pop up into this high cost category and then they fall back down, usually within 9 months. So it may go up for a month or two or to 9 months and then back down. But over time, as we all know, people age, they become less active and their risk goes up, and they often have no symptoms. So this is the money quadrant right here. These are the primary care. This is where primary care has got to rock and roll. These people often don't feel bad, but they're at increased risk of having, hypertension, of course, is a great silent killer. A third of people with diabetes don't know they have it. Plaque doesn't hurt. Stage 1, stage 2 colon cancer, you don't know you have it. Breast cancer, cervical cancer. So these folks are gaining risk, but they don't feel bad. So they don't know that they've got a problem until bam, they're having a heart attack, stroke, the cancer stage 3, 4. They end up, substance abuse, inpatient mental health issues, musculoskeletal surgeries, et cetera, et cetera. And so you all know that this is the 8 to 10% that's spending 80% of the money. So this is the conceptual framework that Alan and I synced up on back in 2019.
So let me add, prior to us engaging with Scott and Converging Health, I think we did a reasonably good job in the healthy people in the left lower quadrant, many initiatives to keep people healthy. And we had many, many people call super utilizer projects, or the people in the right upper quadrant. But unfortunately, we spent so much time on people that were, so sick, or so much time on people that were so well that we missed this whole right lower quadrant where, as Scott said, that's, where the money is, but more importantly, where you can make a bigger bang in preventing sickness and promoting health.
Well said. So here's the actual data. We've got 96,000 people in the Medicis Jamaica system. That's 55%. They don't spend a lot of money, about $600 a year. It's $54 million, which is 7% of the total spend. Bam, we get pregnancies and the acute problems I talked about $18,000 now per year. It's only 3% of the spend, but it's $22 million, so it's an appreciable amount of money. But over time, these folks move over here, and this is the 31% of people spending 16% of the money. It's about $2,000. But unfortunately, this isn't $2,000 spent intelligently. This is often reactive. It's that occasional emergency room visit. It's going to specialists and having 3 doctors that you're seeing, but they're not coordinated and integrated in their care. It's getting CTs, MRIs, often redundant. So this is the opportunity for primary care, advanced primary care, particularly, to make a huge difference. Because again, here's 23,000 people spending $26,000 a year each, 74% of the money. And once people get into this quadrant, they often get lost from primary care, because now they've got multiple specialists in and out of the hospital. They've got cancer, they're getting chemo, radiation, they're having surgery somewhere, et cetera, et cetera. So primary care loses control of people in these 2 quadrants, but they can really, really perform well in this right lower quadrant. So that said, yeah.
And looking at the risk scores, by utilizing the risk scores, it enables you to go from a reactive model of healthcare to a proactive model of healthcare. And it's really been exciting for our providers to identify these people and reach out and try and prevent the big bad things from happening.
Yeah, and you can imagine this is a restrained, a resource constricted environment, because there's not a lot of money to hire a bunch of people. So we don't want to focus those resources on the worried well and the people who can fill the clinics, but they don't have a lot of risk, and they're probably not going to have terrible things happen to them. We, of course, need all the support services and guidance for the the people who are on fire, basically, that need help. But this is the leverage point. So here, real quickly, is to give you a feel for the 3 things. The absolute risk is, let's just go low, medium, high. You have healthy, straightforward conditions. The primary care is key in primary and secondary conditions of focus. When you get into middle, they start to get the chronic conditions. They are on multiple medications. They may have 1 to 3 providers. They need support and they need help, and they probably need to be seen at least every 6 months, if not even a little more frequently. And tertiary prevention becomes important. And then you've got people who have a lot of HCC codes, 3+ providers, 5+ medicines, and they're very, they need intensive outpatient care. And this is what most primary care practices are not prepared to handle. When we look at clinical quality, we have people who are getting the appropriate care. We have people who have gaps in care and they're off course. We call it in the ditch. From the yellow brick road is appropriate care. Too much care is one ditch, not enough care is the other ditch. And they're starting to fall off into the ditches until finally they aren't getting appropriate care. Either they're getting too much care and like surgeries that don't belong, or they're not getting any care because they don't know what to do. And so these are people who we've got to get in. And then finally, when you look at their mentality of using the system, we've got people who get it, who are using the system well, people who are off and on using the system okay, but there's ER visits, urgent care visits, specialist visits that were unnecessary. And then we've got people who are just wandering around reactively getting care. They don't take their medicines. It's a mess. So you can see that on the risk score, that between a risk score, these are just numbers. It's not profound or anything. It's between 0 and 34. Those are low risk folks. 60 or more, they really need a lot of intense help. And in the middle is where we can make a huge difference in primary care. We can make a huge difference in high risk people too, but we need to not forget about those people who have not yet started to fall off the donkey cart. And so
and the scoring system enables you to focus your attention on care that matters rather than just checking a box that you've done something. We're focusing the care on the folks that need it the most.
Amen. So this is the system that Alan was talking about, that kind of we walked into in January of 2020. They basically have a really efficient call center at filling schedules, and the metrics they were looking at is the percentage of the schedule that was filled. And the problem was that by filling the schedules, now the high risk people would call in and they couldn't get in. There was the ACR, they call them ambulatory care registrars. They basically check people in. The patient care representatives, which most of us would call an MA, would get them in the room and get the vitals done, and the clinicians would get their codes, get them in charts, and get them closed. And the next patient, trying to get 25, 30 people in a day. They had patient navigators that opened the mails, they did the referrals, and they would call patients to complete the paperwork on a pre-visit. And they had LPNs and RNs that would go and give shots and do this kind of the clinic staffing and the on-site clinical policies and procedures and case management that were chasing patients as they got out of the hospital. What you got from this is a lot of codes, a lot of CPT codes, and you got very busy clinics. But the problem was that it was exhausting, and the people who needed to get seen weren't getting seen. So what we did in Working Smarter, Not Harder is Alan and Dr. Tulo worked with Mike Tuggy and Jed Constance and myself. And we started by figuring out we had to change the model. There are 4 keys. We had to have the risk, and we had to make it available to everybody, from the call center to the patient navigators, the case managers, everybody. We had to get the right people in the clinic. We had to document the care plan. And the way we do that was these special visits called high value visits, which are very well structured and result in a care plan being documented inside of Epic, where everybody on the team knows what's going on. And then finally, by having this risk stratification and having everybody know about it, and having the HCC codes, the care gaps, the medication non-adherence, all focusing us on getting those people in, everybody does their part. And then we have a scorecard, and I'll show you some results of that in a minute. Alan, I'd love to get your thoughts on kind of this rethinking of how things happen.
So, we were really, low mentally, low physically. COVID, really wiped people out. Morale was horrific, and we were all on that hamster wheel, and people, providers and staff alike were all, dissatisfied with their lives in our sites. We were kind of running, I call it like the 1970s, 1980s Medicaid clinic mentality, get them in, get them out, send your bills in, like Scott said. And we changed the system around, 180 degrees in a totally different direction, especially about, satisfaction of patients, satisfaction of providers. Like, we all need to be happy, and getting people into the office that need to be into the office, and giving care to those people that need it most at that time.
Amen. And so let's just review that real quickly. So now what happens is the operators are shifting. This is in transition. You got to realize we're only, by the time we did the assessment last year, and then we figured out what was going on in the system, and then we redesigned the flow, and then we had the whole Jamaica team, and we identified one clinic, and we implemented it in the last quarter of 2021. We really hit the ground on January of 2022 with with an operational model. And so this is still in transition, but you're going to see the results in just a moment on that first clinic that we did. So the call center operators now shift from filling schedules to making a good first impression, understanding a little bit about what's going on with the person, and then activating the appropriate resources. And if the risk score is high, they have access to it. They can see it. And if the risk score is high and the person is not just calling for a routine visit or a medication refill, then we need to get them into the clinic that day. And what we were finding is that people would try to get into a clinic, and two things would happen. Either they'd go to another doctor that they didn't know and didn't know them. And this is a complex person. So often the care was very hard for that person to get up to speed, to that doctor or nurse practitioner to get up to speed and figure out what's going on and get the person taken care of, or they'd end up in an emergency room from often another hospital, not a Jamaica hospital, which is very frustrating. And then they would get, inappropriately intense care, redundant CTs, redundant labs, referred to specialists, and boom, they're out of the system and going the wrong way. So, but the LVNRN now plays a different role. Instead of they still do the schedules and policies and procedures for the clinic, but now they're the clinical resource that when we have to make a call, it's a low risk person who maybe has some burning when they urinate or they have a rash. How do we get them in quickly? And can we do a telephone visit with the provider? By the way, we restructured the entire schedule. So now there are 14 visits a day on the routine, kind of the high value visits or the routine follow-ups. There are 2 visits in the morning, 2 visits in the afternoon that are for walk-ins for high risk people particularly. And then there are 2 telemedicine visits a day. So, and those, can be a high value, could be a high risk person, but often those are for people who are low risk that just need some guidance on what to do. So the LPNRN is playing a more profound clinical, making a bigger difference in how people are routed through the system. The ambulatory care representative really is all about establishing rapport. We've shifted from a transactional mindset to a relational mindset. And I think that's really the key. So this is about building loyalty, building trust, and building rapport. So they greet them. The patient access representative, now their role is expanded because we have inside the Epic system, they have, what are the HCC codes need to know, what are all the gaps in care, and we're actually seeing the people who need those things and creating care plans, which is what the clinician's all about, is creating the care plan and putting it in the Epic chart where everybody can see by diagnosis what the care plan is, and they can leave, they can set the path forward and leave a trail of this is what we need to do depending on what happens with the next step in this person's care. And everybody from the call center to the RN, the patient access representatives, and the navigators are seeing that. So now we get everybody pulling on the rope. And I have this mental image in my mind of the old model was everybody was sitting on the cart, if you will, and the doctor had the rope and they were trying to pull the cart forward. Now what's happened is everybody is doing the part, they're grabbing the rope, they're pulling things forward, and the patients are the ones that are on the cart instead of being lost and out around the system. So it's redesigned it. And finally, just real quickly, the case managements, they're now managing transitions of care and communicating with the navigators and the LPNs on our ends to get people in. So this huge burden's been taken off the clinician and moved to so that everybody's working at the highest level of their license, and nobody does something that somebody else could do just as well. That's the aspiration. It's not there yet, and it's only in one clinic that we've really been able to focus on this, but it's made a huge difference so far. What do you think, Alan?
I agree. You know, we went from, especially in that site, and we're about starting to move to the other sites with this model. But, you know, we went into offices where people were, the waiting rooms were packed with people that didn't need to be there, and there was no room for the people that needed to be there. So we totally changed the mindset from proactive to reactive. And again, I love Scott's term of working smarter, not harder, where we are really doing that. As Scott said, utilizing people to the top of their licenses. So our docs are not filling out paperwork, you know, all day long. And it's giving them time to deliver the care that matters rather than care that doesn't make such a difference in people's lives. And, you know, the patient satisfaction and the provider satisfaction has moved astronomically in a very short period of time.
Yep. So here, does it work? Let's just look at the results of the pilot. It's East New York's the clinic that we did. The 4 primary care providers, one of the busiest clinics in their network, and, you know, kind of a big challenge. So if we're thinking about it, there were 4 questions we had. First of all, is limiting the schedule like that, because instead of having an open schedule for 24 to 30 people, we shut it down to 14 and only open up the schedule theoretically the day before, kind of the day before that day, the schedule's open so we can get all the walk-ins in. Now, in practical reality, sometimes it has to be a little more flexible than that, but you get the idea. So the first question is, by changing the schedule, are we going to decrease the volume and hurt, if you will, the throughput of the system? Second was, are we really figuring out what's wrong with people? This high value visit we talk about, which if Mike Tuggy was here, he would say that's really the sentinel thing that we've done. That's a 40-minute visit where that doctor or nurse practitioner looks that person in the eye and creates a care plan for all of their major diagnoses, or at least the top 5, and documents it in a way that everybody knows what's going on, and is able to delegate to the patient care representative and to get the things done that need to be done. And then there's a magical moment that occurs. And Alan, I want you to tell about the magical moment that really the clinic figured out, and when the clinician has finished seeing the patient. Oh, you're on mute, Alan. You're still on mute.
Sorry about that. Yeah, I mean, there's been a total change in what they're seeing. So that the providers are now taking care of complex issues, the menial kind of things that they were doing as far as documentation and forms has been minimized, and we're now delivering care that matters to the people that matter it. And the numbers are showing. So the doctors are now starting to get real live data. They have data on the risk scores. They have data on financial scores. They see where they're making a difference. And like I said, the satisfaction is just huge.
Well, and Alan, comment on the way they changed the colors, because I think that was one of the things it was not on my radar screen, but on the schedule, you've got different colors of things. And to me, the magical moment, the thing that I've heard from all the doctors I've talked to, is that when they're done with creating the care plan and they're ready to go to the next room, they basically do something on Epic, and it changes the color so that the appointment changes color, and the patient navigator knows at that moment to walk in the room.
So we now have a system without speaking to each other of a dot system that's in the chart. So we know when the patient has arrived, we know when the patient is registered, we know when the vital signs are done, we know when the navigator has started with the patient, we know when the provider and the MA and everyone goes through. So it's really created a system of efficiency without people having to, get on the phone and who's in room 7 and things like that. So it's created this system of efficiency, and the providers are excited just that they see that we're looking at everything they do and they know they're important.
Yeah. And, you know, I never forget, there's one doctor, Dr. Conado, who's you may know him because he's been involved in FMEC. And he said, you know, in the old days, it was like Groundhog Day. I'd go in, I'd see the patient, I'd say, this is what we need to do. The patient would get up, they'd walk out of the room, they'd go to the front desk, they'd schedule their next appointment, and they'd go home. And then things weren't followed up on properly.
Well,
And
more often they wouldn't go to the front desk. They would just walk out without the follow-up. So,
yeah,
you know,
yeah.
we created internal systems of efficiency.
Yeah. And so now the navigator comes to them, schedules their follow-up, schedules their referrals, schedules any lab work they need, schedules any imaging they need, make sure their medications are all refilled, answers any questions, and says, if you have questions about this, here's how to reach me, and actually gives them a card that says, here's how you reach me directly, quickly to answer your questions. And Dr. Conado says, it's just remarkable. His whole life is transformed because now, instead of the patient coming in 3 months later with the same problems and him having the same conversation and things not moving ahead, now things are actually happening and patient care is moving aggressively forward and transforming. And it's very exciting, as Alan said. So here's the data. All right, so you can see that we were doing our assessment. We were trying to figure out what was going on. This is the East New York clinic. And then we implemented it in January. So it's right here. And what you see is throughout this year, the number of visits are going up at the clinic. They're not just staying flat, which is kind of exciting. And a little surprising, to be honest, but it's working exactly the way we want it to, because the low risk people are getting their quick visits taken care of, and they get taken care of without spending and clogging up the system a lot. The high risk people are getting the high value visits, and there's a synergy that's starting to occur. And as Alan said, they used to have a line of people, 25 people in the morning when they got there, that were waiting to walk in. Now there's no line in the morning, and the waiting rooms are 50% less filled because people know the system's going to work for them. The second thing is, in a fee-for-service environment, of course, we look at how much revenue the clinic generates. And the clinics still have 20 to 40%, depending on the clinic, of fee-for-service. So we were worried that we would hurt that. And you can see that actually they still bill the Medicaid full risk plans. So we can use this as a surrogate to productivity and how much they're generating. And it's going up, not down, which again is very exciting, because we look at the number of high-risk patients that are being seen by the doc. And what we see is that has gone up dramatically as the staff is now getting the right people in front of the provider. So the provider just gets to go in, talk to the person, do the care plan, call the navigator in, and the system works around the provider to simplify and make their life easier and better. And we see both the number of high-risk patients being seen and the number of these high-value visits per day going up dramatically. So it's doing a better job for the patients. It's getting the right patients in. It's making life easier for all of the staff, and it's increasing productivity. So it's fantastic. And just to put a cherry on top of that, we've done a survey in the last 4 weeks. And these are the initial results, where we have the people at East New York. And we asked them just 5 questions. Over the past year, how have things changed for you? Over the past year, how much do you enjoy your work? Has it changed? The clinic's ability to care for patients, sense of working on a team to care for patients, optimism toward the future here at work, and the feeling that I'm making a difference. And you can see that on a scale of 1 to 5, all of these responses are a 3, 4, or 5, and the majority of them are 4 or 5. And I have the results for the clinics that we haven't implemented this yet. And you see the distribution is much more of a standard deviation, or a standard distribution, where 3 is the center of gravity. There's some 4 5s and there's some 1 2s. So this is actually shifting it. You can read the comments at the bottom, where the staff is feeling empowered. They're using their skills. I don't know anybody who went into medicine to become a blood pressure checker or a check-in person. Everybody wants to save people's lives and help them live a better life. This is actually letting every member of the staff realize their purpose in life and in transforming communities.
Yeah, I mean, it's been amazing. You know, we've really change to an advanced primary care model. We're delivering the care to the people who need it when they need it. And people are working smarter, not harder, and people are happier. Our patients, our staff, everyone is just much happier. It's working, and we look forward to bringing this to our other 11 sites in the next several months.
So Larry, are you there?
I am here. And, I've had the great privilege of really being a lurker. I've been on site in New York City. In fact, we'll be there in a couple of weeks to follow up, and it is truly amazing. And when we talk about redesigning the U.S. healthcare system from the ground up, I appreciate that this is one organization in one community, but it really is a model, and that could be replicated and scaled really in any healthcare system or independent practices. The core ideas here are just good family medicine driving the performance of the system. And it's been very exciting to hear the docs and to hear the staff talking. Their motivation is up, and it's just very exciting to be a part of this. So I want to congratulate you guys and take some measure of pride in having brought people and ideas together to get things done like this. This is what we need to do in our country.
Well, thank you. I have to really acknowledge Alan for having the foresight to see it. He also has worked so hard, and he has so much respect of the leadership and the medicine system that, when Alan speaks, people listen. And so he and Dr. Tullo and have been able to get their administrative leadership to embrace this and to pay for all these changes. And it hasn't been easy, and it hasn't gone smoothly all the time. So it's taken us a lot. This is the first time we're doing this on this scale. And so they've had to put up with Converging Health, really getting its act together and integrating all this data and creating all these new dashboards and data analytics in the platform, and operationally, it was really to me moving to see how the staff embraced this and pulled it toward them. So, Alan, kudos to you and your leadership. Thank you.
Well, it's been great working together, and we look forward to continuing it.